Well, thank you, everyone, and good afternoon. And it's thank you for this opportunity for Laura, myself, and Francis to share our experience of co-designing our integrated palliative care model in Mississauga Health OHT. So this slide just shows you a little bit about Mississauga Health, and that's the name of our OHT, Mississauga Health. Our vision is to improve the health and wellness of all people in our communities by connecting their care across the system. What's really critical there is the health and wellness. We're focusing on both health and wellness and across the system. You can see that our Mississauga Health has 900,000 plus in terms of our population. I think we're one of the largest OHTs. We have a lot of people in our OHT without family doctors, and we have about 40% of our population coming from our boundaries, which is really important for us to consider. And it's a very diverse population in our region. Back in 2019, when our OHT was formed, we looked at, in terms of improvement opportunities, we had identified palliative care as an improvement opportunity. And that was because we heard from partners that there was an opportunity to improve people's experiences and access to palliative care, but also the data showed that improvement in palliative care was important. Only 62% of people in our region 62% of the people in our region did not have access to palliative care. And of the people that did, only half received their services in the last 2 months. So we knew that people in our region were not getting, a lot of people in our region were not getting access to palliative care, and those that were getting access too late. And so that was the inspiration behind us making palliative care a priority in terms of our work. And so if I go to the next slide, I'm going to talk a little bit about our journey in terms of developing an integrated palliative model. So we came together as partners, and you can see that on the right-hand side of the slide, we engaged all of our partners, patients, families, caregivers, community, our hospice, our hospitals, our primary care, home care, service provider organizations, all of our partners across the care continuum, along with our Institute for Better Health, as we talked in the last poll around engaging researchers, as well as Ontario Health in terms of engaging government as well, to come together to form what we called our Palliative Care Collaborative. Together, we created a shared vision and a shared purpose in terms of what we wanted our palliative care system in Mississauga Health to look like. And so our shared vision is, together we deliver exceptional and connected palliative care every step of the way, because everyone's experience matters. Our partners came together initially as a group to co-design, and I'll talk a little bit about the co-design, to co-design the model. And now we have created a governance model which sees all of these partners coming together in what we are calling our palliative care planning table to provide ongoing strategic oversight, guidance, and decision-making support as we move towards planning the implementation of our integrated model. And then we'll provide oversight as we operate our model in future. Our objectives for our integrated model very much are twofold. We wanted to design and implement an integrated model in our region, as well as build capacity and competency in palliative care to achieve the quintuple aim outcomes in terms of improving provider experience, outcomes, and provider-patient experience and outcomes, as well as ensuring equitable access to care. This is our journey in terms of how we co-designed our integrated model of care. We looked at our current state. We knew we were delivering good care, but we knew that access was limited and it was poorly coordinated. We built upon previous work. There was a history in our region of our palliative care network coming together and doing a lot of work around palliative care. So we looked at information from the co-design sessions they held in past. We looked at using the Ontario Palliative Care Network health service delivery framework for palliative care that guides, that defines a model for how palliative care should be delivered in the community. And that's the basis of our model. And then we also looked at population health and looked at the data in terms of what the needs of our community were to help inform our model. We then undertook co-design. We held 4 sessions, co-design sessions with all of the partners that I've listed, to come together to really understand our current situation, the problem, to identify opportunities for improvement and going deep into these opportunities, and then bringing it all together to create a model for the future. We also are now moving into the planning and implementation stage. So over the last year and a half, we've been working on planning how we're going to implement and operationalize our model, and we are hoping to launch implementation in the fall. So I love this picture, and I loved, I think Carrie talked about it, collective impact. This always reminds me of collective impact when I look at all these beautiful smiling faces of all of our partners coming together, including our patients and caregivers. I will tell you, those co-design sessions we held, there was a lot of creativity, ideas, innovations, and diverse thinking that really reflects the value of bringing partners, diverse groups of partners, including patients and caregivers, together. So we had 21 organizations that attended our co-design. We had 68 people invited and 52 people attended all 4 sessions, including 5 caregivers and community members. So in terms of engaging with patients and caregivers, that's a central pillar and approach that's important to the work in Mississauga Health, including the work of our integrated palliative care work. So as we, in our integrated palliative care work, looked at how are we going to engage and co-design with patients and caregivers, we reflected on and we built upon the Declaration of Values, the Ministry of Health's Patient Family Caregiver Declaration of Values. We also built upon and sought guidance from our Mississauga Health Community Health Advisory Network. This is an advisory network of patients and caregivers who are advising the Mississauga Health OHT on ensuring that we are engaging with patients and families. And what they told us was a few things that we incorporate in terms of our engagement work. They said, ensure that you're seeking the voices, diverse voices, not just the voices of a few, but the voices of all diverse communities. Make it easy for people to participate and acknowledge and support them in that work. And so those were some of the key pieces that we took away from our Community Health Advisory Network to help inform our engagement work. Some people may be familiar with this. This is the International Association for Public Participation. It's a framework that provides a spectrum of the various ways that patients and families and the public could be engaged. Right from informing, consulting with them, involving them, collaborating with them, and empowering, which is really where they are at the decision-making table. So from our perspective, what we did was we took this framework and we developed a plan for our integrated palliative care work, not in terms of designing the model, but also also for implementation and then program delivery. What are the ways that we can inform, consult, involve, and collaborate, empower our patients and caregivers through all of the co-design, implementation, and program delivery? And you'll see a slide in the appendix when the slides are sent out. On slide 19, we have our plan out there, which really articulates why are we engaging, what we hope to accomplish, what we commit to our patients and families in that engagement process, and what we will do with the feedback we receive. Based on that framework and our plan for engagement, we incorporated engagement with patients and caregivers in multiple ways. So patients and families, patient and caregivers are empowered and are decision makers on our planning table. They have a vote, and they are key members of our planning table, along with all of our working groups that we have for our integrated model of palliative care, as well as some of the digital solutions that we are developing. And the other thing that we have done is we have provided multiple ways for patients and caregivers to engage. One of the feedback we heard from our CHAN, our Community Health Advisory Network, is people want to engage in different ways, and they have different capacities in terms of time and ability to engage. And so they challenge us to provide multiple ways. And so a couple of things that we did was we provided opportunity for caregivers just to share their story one-on-one. And we did that with the view that to hear their story, to inform our model, but also to inform current decision makers in the system who could make things better, perhaps right away. And so we had Ontario Health at Home in these sessions. We had our OHT, we had partners from various organizations to hear the stories, and that was really, really powerful. We also had various focus groups where we invited folks to share their stories. And then we did interviews, particularly for diverse communities. We sought out to have one-on-one interviews to seek feedback, to make it easy for people to provide input. So again, looking at multiple ways to provide feedback, multiple ways for patients and caregivers to engage. Some of what we did in terms of engagement and some enabling strategies for us is we recruited interested patients and caregivers from our palliative providers, through the hospices, through the hospitals, through our home care providers. They identified people who would be interested in participating and providing their input. We again looked at working with our organizations that served equity deserving communities and went to them to seek feedback and input as well. And then the other thing we did, and I think Carrie touched on some of these, is we really looked at ways to make it easy for people to engage. So offered evening participation. We looked at technology in terms of the chat function, but also Zoom is better than Teams for a lot of folks. We looked at, we had a one point of contact for patients and caregivers who would follow up after every meeting. We offered patients and caregivers to write an email with their written thoughts. So just multiple ways to make it easy for people to provide feedback. The other thing we did was we offered an opportunity for recognition. I think we often forget recognition in terms of thanking our caregivers. We had 2 socials, as we call it, where we brought our caregivers together so they can connect with one another and share their experience, but also to thank them for their experiences. So these are some of the things that we did, and it really, I can't say enough in terms of hearing from the diverse voices of our patients and caregivers and the difference it has made to our model.
So I'll try to get through this quickly so we have lots of time for Frances to share her experience as well. So this really just sort of what was our output, what did come from this. And so this slide really speaks to the OHT's goal of taking what was actually in our region is a system where we have all the players for palliative care, but we weren't functioning as one system. We were kind of working in parallel, or the front lines were, but the systems that govern the front lines weren't necessarily planning together. So really trying to bring us all into one umbrella with the Mississauga Ontario Health team, using our provincial map, which is for palliative care, the health service delivery framework for adults residing in the community as our kind of gold standard of what we want to achieve. But the how we get there and what are the nuances of that for our region is what we co-designed with all of our partners. And I think everything Carrie shared earlier in terms of hearing from those frontline experiences really has informed the model that we created. This speaks to all of the key kind of change ideas by the phase of care in the palliative care world, sort of from the point of identification through to end of life grief and bereavement, recognizing that some of those elements apply to all of these different areas in the trajectory of care, and others are really specific to a phase of care, but really working through what does this look like for us locally, what is building on existing and what actually is new. You'll see, I think we've rolled it up into 5 really key high-level points, and this really sums it up best in terms of having a process for earlier identification and all the sort of elements that we heard. It's not enough to just identify patients. You actually need a system of care that's ready to receive them. And that might look different or expanding on the existing system, which really is number 2, our integrated palliative care delivery pathway. And it's green because that's where most of our starting work is happening, because we really felt that we need to beef up our current system in order to be able to have some of these other elements be successful. And so we'll share a bit more on that phased approach of sort of navigation point person, 24/7 support, really working as a team. And we've used some of our levers in terms of existing projects that we're doing now to move this forward. The foundational building blocks, what Dipti spoke to, we need a governance structure for this work. It is new, so we've co-designed it, which is great. But in order to continue that conversation, we actually need a way of coming together to continue the conversation as we move through our change. And then the newer areas, I think things that maybe wouldn't have come out as strongly or as their own bundle if we hadn't had caregivers in the conversation, were elements 4 and 5 around grief and bereavement. Again, lots of resources do exist, but the way we access them, the ability to know about them is highly variable. So really making that more consistent, as well as an entirely new caregiver pathway where we recognize in palliative care always have that caregivers, family are a huge part of our patient unit, both in terms of supporting them through caring the patient, but this idea that actually a caregiver needs their own care plan in order to sustain them in both the emotional, the physical, and the practical journey. of supporting a loved one with palliative care needs. And so this is emerged as its own work stream, which I don't think would have been there. And I'm so glad that it is, if we hadn't had our patient care partners, caregivers in the co-design. This is just sort of explaining some of the elements of our model. It's going to be a phased approach. We're not doing this all at once. And you can see the elements on the left are really where we're starting and planning to build out the rest as we go forward. On the next slide really just highlights the 4 areas where we're currently most active in terms of building that integrated care team that I highlighted before, using our home care delivery transformation through the leading projects as our key enabler to that change. Our digital collaboration tool had its own entire co-design process that was separate from the integrated model co-design, using the same elements of who we engaged and how we engaged them. And again, this governance structure, which will serve as our sort of path going forward of how do we continue to make sure we're still having these conversations, checking in. And that readiness of partners to make the change, I think has been such a key element of the success in this work and continues to be. Really, what did we learn through this process? One is that importance of working with local priorities. You can have a great idea, but if everybody else isn't kind of on board, it's less likely to have momentum. We did capitalize on previous relationships. We started our Ontario Health team in palliative care with very strong previous relationships, and that was another reason beyond the clinical need why this was a starting area for the OHT, because we had a structure, we had people used to working together, and we've continued to build on that. We've leveraged initiatives, so the Home Care Leading Project, our digital tool, these were all opportunities that presented themselves, so we've kind of helped find our path forward by leveraging those moments. Patients and caregivers have been key to better outcomes in this work and will continue to be. We're sort of in an operational moment right now, but strategically they're super key. And I think we have done things differently because of it, and will continue to do so. And this concept of leading collaboratively, this isn't any one organization's initiative. This is all of our initiative, is also key to moving this work forward.
Good afternoon, everyone. I'm very pleased to be here. In April 2022, I was asked if I would like to participate in the co-design of an application to assist healthcare providers in creating a more connected, easier to access palliative care service for patients and their caregivers in Mississauga. I had been a long-time volunteer at Hospice Mississauga, which formerly was called Hospice of Peel and Heart House Hospice. And I had been the primary caregiver for 2 husbands who had required palliative care. It was a real honor to be asked to help the OHT. For some loved ones and friends, their final journey has been extremely difficult, and our healthcare system did not always meet their needs. The opportunity to be a part of the MOHT team, whose goal of making everyone's journey through a terminal illness better, was one I could not pass up. I was really heartened to see that the group's focus was to leave no one behind in providing access to a better palliative care journey. They recognize there are a good number of people that need special consideration. Those who are new to Canada, those whose first language isn't English, those who do not use computers or do not have the use of one, those who have no family nearby to help. Another special group that was added to be part of the plan are those who are suffering from incurable chronic diseases. Their palliative journey will be longer because of the complexity of their disease, and their needs for help will wax and wane. My 2 experiences as a caregiver to a terminally ill loved one were very different. In the late 1980s, pain management was very poorly handled because of the fear that the patient would become addicted to the medication. It was a huge battle then to get the doctors in or out of the hospital to change their attitude towards managing pain. Thankfully, that does not seem to be as much of a problem today. Yet I do know there still are some patients whose pain is not well controlled. The hospices do a wonderful job to ensure their patients have a peaceful, pain-free passing. And the same comfort should be available to those who choose to die at home. Over the many months of participating in this project, I became more and more impressed with the dedication of the attendees from many diverse healthcare providers to develop this integrated model of palliative care. The task of delivering exceptional palliative care across the continuum from diagnosis to end of care to post-death support would require all of those providing services to the patient to be on the same page. So the idea of a navigator who would be the hub into which all of the health services connected as needed really resonated with me. To have one person collecting the reports of the variety of services provided to a patient over the varying stages and needs of that patient would be so much more efficient. I also welcome the group's acknowledgement that the primary caregiver is an important member of the healthcare team in managing the palliative journey of the patient. When a problem arises with the patient's condition, the caregiver sees it first and can be uncertain who to call for assistance, especially if it is after working hours or on the weekend. Having that one number to call would be a great comfort at those times of great stress. And without that support, well, the ambulance is called and the patient arrives at the emergency department. And this is not a desirable consequence for the patient or the hospital. And it could be avoided in most cases with the support that an integrative palliative care service plan is designed to give. I have nothing but admiration for the medical people who have been working so hard for 2 years to bring this initiative into being. They have always invited and accepted the suggestions and comments that our small group of caregiver participants have offered because they have understood that our part in the patient's palliative journey is an important component. Many patients want to be cared for in their home, even up to their death, and the integrated palliative care plan that is being designed or has been designed makes that more likely to happen. Who wins in this circumstance? Well, the patient, the family, the hospital, and the healthcare budget. My only frustration is that the implementation seems to be taking a little too long to be approved. Hundreds of hours of work by very knowledgeable people who are dealing with palliative care every single day should not be wasted and should not be delayed. If Ontario wants to be seen as forward-thinking, innovative, budget-conscious, this plan is a winner. There are no negative outcomes for anyone here. And I hope that those who can give the go-ahead will recognize that and approve the urgently needed integration plan for palliative care that has been developed by the MOHT so that it is in place before the end of 2024. I'm dreaming big, but I'm hoping I can I can see it done. And when I say I mean the whole group that has been working on this. We want to see it done. And I would strongly advise other OHTs that are planning changes to their care delivery to reach out to caregivers in their area and invite them to participate in your discussions and planning right from the beginning. They are the people on the front line of patient care, and their experiences will be real and valuable to you. And to any caregivers who are approached to join such teams, I hope you will. Your voice is important, and you will be heard. Thank you.